It's one of the most unsettling calls a pediatrician can get. A baby who turned blue, stopped breathing, or suddenly went limp, and then just as quickly appeared completely fine. Welcome to the clinical gray zone of BRUE. BRUE sits at the intersection of alarm and ambiguity, where the history is often dramatic, but the clinical exam is reassuring. We're going to go beyond the definition and into real-life decisions that you have to make on the phone and in the office. From risk stratification to avoiding unnecessary testing, we break down what actually matters in the moment and what doesn't. This is Charting Pediatrics. Tonight, we're on the road with Charting Pediatrics, and we're thrilled to be engaging with our provider community here in Colorado Springs. For this episode, we have two amazing experts. Dr. Michael DiStefano is the Chief Medical Officer of Children's Hospital Colorado in Colorado Springs and a pediatric emergency medicine physician. Dr. Jamie Hugg is a pediatrician here locally in Southern Colorado at the Children's Clinic of Pueblo. Mike and Jamie, welcome to the podcast.
Thanks.
All right, thank you for having us.
Mike, let's start with this acronym BRUE. First of all, tell us what it stands for. And for those of us that trained a while ago, we remember ALTI. Is this the same thing? And why do we change names?
So BRUE stands for Brief Resolved Unexplained Event. And yes, it is the same thing as ALTE or ALTI. The Academy of Pediatrics changed it in 2016. And I don't know if they changed it to a better term, but it's definitely less alarming to families. I think challenge, especially in the emergency department, is they get a discharge paper and they see life-threatening event. Now they don't see life-threatening event. They see BRUE. However, it still doesn't really help guide the families. And there's still, as you mentioned, a lot of ambiguity to exactly what happened.
Yeah, they see that in their discharge paperwork. They turn right around and come back in.
Yeah, we try to prevent that in the ER.
So Jamie, I'm wondering as a pediatrician, if you get a phone call or you see a patient in clinic with this story, what's going through your mind at that moment?
It's a great question. It's really, does this meet the very definition of a BRUE? So what exactly is a BRUE? It's a brief event. So brief being less than 1 minute. It's resolved. So the baby is back to baseline. It's unexplained. So we don't have an identifiable cause for it. An event. So at least one or more of the following have to happen. There has to be a color change. So are they pallor? Was there pallor, cyanosis, an abnormality of breathing, where it's absent, decreased, or irregular, a marked change in tone, so hypertonia, hypotonia, and an altered level of responsiveness. So I'm thinking to myself, if I'm getting a call or I'm hearing about this, does it truly meet the definition of a BRUE? And if so, are they back to baseline right now? Should they come on in and see me? Or if they're not back to baseline, should I be sending them over to Mike in the children's ER?
Thanks. And what's the age range we're talking about?
Yeah, great question. So, for a BRUE, it has to meet certain risk stratification. So there's low risk and there's high risk. So for low risk, it's greater than 60 days old. They have to be greater than or equal to 32 weeks gestational age and greater than or equal to 45 weeks post-gestational age. It has to be one-time event, less than 1 minute. There has to be no CPR by a trained provider, and the history and physical have to be very reassuring. Nothing alarming, no red flags in there. So we're talking about kids greater than 60 days old.
So Jamie, thank you for that. There's a lot of aspects to these guidelines and recommendations that you have to think of. Yes. Mike, when a patient like this comes in the emergency department, how do you remind yourself all the things you need to keep track of to appropriately risk stratify?
Yeah, Jamie described that perfectly, of high risk and low risk. And, I think today in 2026, it's really around sort of the history and physical. That really drives my decision making. I think when the Academy came out with BRUE, they thought they were doing us a favor and they were going to risk stratify these patients. Interestingly enough, I think it's almost greater than 90% of patients fit the high-risk criteria. So they essentially said 10% do not need testing, and then they have 90% that are in this bucket of what do you do with them, and they did not help drive any of that decision making. So it's a big challenge, especially when you have families who really feel like their child had an event that was life-threatening and they almost died, right? And how do you
real-world
navigate
experience, only 10% are fitting into the low risk?
That is correct from my understanding. Yeah, and from my experience, that's about right. So and it's because they fit in. The way the Academy had defined BRUE and high risk, low risk was at that 60-day mark. It was very dichotomous, meaning that if you're less than 60 days, you're high risk. If you're greater than 60 days, you're low risk. But the reality of it is, majority of kids who end up having these BRUE events are in that high risk. I use that very loosely, high risk category.
So the young infant. So what's your decision making then? So you do your history, you do your physical exam. What is the pathway afterwards?
Yeah, so physical exam, if they're normal, I think that makes it a lot easier. History is really driving how I think about the workup. So if it more sounds like seizure-like activity, if this seems like there is a history of reflux, arching with feeds, that kind of points me into a certain direction. But the reality of it is how do I reassure family? And that can be a big challenge. You know, the Academy said 1 to 4 hours of observation, but a lot of times they need more than that. And so I really think about this as shared decision making with the family, because we can't go home with them, right? You give them their baby and said, good luck. And so we need to make sure that once they leave, they understand risks and that that likely they're A-okay, but sometimes we need to admit just for family reasons.
So Mike, obviously you have a lot of resources available to you in the emergency department in terms of diagnostic evaluation, right? That are not going to be necessarily immediately available to Jamie in her office. So how do you think about the evaluation and workup?
So I think it's, on one hand, a little bit easier for us sometimes in that as an outpatient pediatrician, we generally know our families, we know our patients really well. We've seen them before. We know what our families are comfortable with. And so when they come on in, we get to examine the patient. We get to see, are they truly back to their baseline as we, as their pediatrician, know them? How are the parents feeling? Are they comfortable with taking them home? Do they know what to look for, what concerning signs to look for? But I feel as their pediatrician, if there's any ambiguity, if I have any concerns at all, that's when I'm sending them to the ER so that they can have more diagnostic testing.
So Mike, tell us a little bit about the conversation with families, because I think that is sometimes the rub, right? If you're sending families home with anticipatory guidance, how do you have that conversation?
So it starts right after the normal evaluation, and they're on monitors. And I usually reassure them and say, we're going to watch your child for, 4 hours. Usually I'm a little bit on the longer side, especially if they're coming in and EMS was called, CPR was performed. The Academy talked about CPR, and the reality of it is that most families who provide CPR are not healthcare individuals, right? However, they thought their kid died and needed to resuscitate them. So I'll start at that point, and then I get to know the family and understand sort of how much anxiety is in the room. I'm also ensuring that there's not recurrence of an event, because that would signal to me that I probably need to watch this kid for a little bit longer outside of the emergency department and admit them. So it really starts from the very beginning on monitors and getting to know the family, and understanding sort of where are they at, and are they comfortable even taking their kid home. And sometimes we have to compromise. I may think that the kid's totally fine and you're good, but there's a lot of anxiety, and they will be back in the emergency department.
Jamie, how about you? How do you approach that?
I like to ask the parent when they're with me, first off, how are you doing? How are you doing? That must have been incredibly scary that you thought, your kid was dying, or they were limp, or they were staring off, or God knows what. And I like to check in, and I tell people, you know what, if I weren't a pediatrician, I would have been terrified. I just like to be honest about it. I would have been absolutely terrified. It is very normal for you, especially in the next few days, even few weeks, to be anxious about taking your baby home, probably watching them, hypervigilantly. And I like to say, let's examine them. Let's see what's going on. Are they back to baseline? Yes. Great. And then I tell them, this is what we're going to look for. Are there any reoccurrences in the future? If so, bring them back to me. Are there any patterns that you're seeing? Anything concerning? I like to say, this is what's normal. This is what is not normal. And, if they go to the ER, typically they will get infant CPR training so that they'll have more skills. If they don't get that, I like to send them to get that. And I think that just makes them have more knowledge and feel more comfortable taking their child back home. And I say, you know what? You can always call us for absolutely anything. Just, if you are scared, bring your child back.
I like that idea of giving some empowerment to the families. Mike, you're an experienced emergency medicine physician, been doing this for a long time. What are some pitfalls in the evaluation, or some potential things that could be missed in the evaluation of a patient with BRUE?
Yeah, I think if you're not very thorough in your history, you're going to probably miss something if it's there. I think that is probably one thing that I have taken as I've done this for a while, is ensuring that I understand sort of the circumstances of the events and leading up to the events. The exam for me I don't think I've ever evaluated a kid who presented with a BRUE that had an abnormal exam. I go back to sort of, what are the family experiencing at home and what are those symptoms?
I'm wondering if either of you have some memories of patients over the years that you've encountered with this type of presentation, what you remember from those experiences, what you learned from them.
At least for myself, ironically, on Monday, I just had a kiddo where I think it was 68 days old, if I remember correctly, met all the low-risk stratification criteria. And they came in and they said, last night, just woke up, was crying, turned blue for 20 seconds, was limp, and then went right back to normal. And I said, well, how are you doing? Are you okay? And they said, well, we were pretty stressed out, but we were so tired we went back to sleep. And I said, oh, okay, well, let's examine, let's get a good history. And that's when we're going over and we're talking about, is there any family history of sudden cardiac death, of arrhythmias? We're going back over the birth history, just reinforcing, making sure this baby wasn't a preemie, that we didn't miss anything there. Was there, what happened before the event? What happened to resolve the event? And apparently the baby just came out of it. And it's so important to take such a good history, because it could be the difference between one good question that can give you the answer here. But it truly did sound like a BRUE and not what I guess we would call a BRUE, which would be a brief, resolved, explained event. And you just have to give a lot of reassurance and guidance.
You just introduced a new acronym for us.
Oh, a BRUE?
A BRUE. Mike, how about you? Do you have any memories of patients you care for over the years?
I try to forget them. Yeah. It's sort of in this bucket of like unsatisfying diagnoses for an ER doc, right? Like you have nothing to sort of reassure the family. It's this very vague diagnosis. And I didn't know if I was going to disclose this, but interestingly enough, I did research on ALTEs when they were ALTEs.
Well, share more,
and
please.
This was actually a failure of mine. So it actually happened. So I was practicing as I think I was a first-year fellow, and as you go through fellowship, you have to do a academic project, a research project.
So they say.
Yeah. Well, funny, you don't have to publish, and I learned that because I got rejected with my study. But it was on ALTEs, and the reason why was I think I had like 3 kids in one night, and at that time we had did a whole bunch of things. We got CMPs, CBCs, EKGs. We'd admit them for EEG, a pH probe, and I was annoyed because they all looked really good. And so I embarked on research, which was good. I found out I don't like research, and I'm not a researcher. And it was a cost analysis of looking at the different studies. And lo and behold, it's not cost effective to do a big workup. At that time, we were doing all big workups. I think that is very different than today, where we're really sort of reassuring families and not going down this pathway of the $1 million workup and admissions for 3 days.
Sounds like you were ahead of your time, Dr.
Yeah,
DiStefano.
well, thank you. You should email the Pediatrics and tell them that they missed out. And
Reject it.
Yeah.
You were challenging the status quo. They wanted nothing to do with it.
Yeah.
So as you think about, it sounds like, you take a very detailed history. Your physical exam's normal. So much of your time is then spent reassuring the family. What's the appropriate follow-up for a child like that after they leave the ED, or Jamie, in your case, after they leave the office? When do you need to see them back again?
So from the emergency department, I try to get them into their pediatrician at least the next 24 or 48 hours. I think it's important for reassurance. And then also, when you think about it, it is not only scary for the provider, for the family, but could be for the provider, right? Because these are events that historically were named near-miss SIDS, right? We were thinking this was something that got, for whatever reason, the course for that patient changed, but could have potentially led to a SIDS event, right? And so I think from a provider perspective, I think less so now today, but that really ensuring that they have close follow-up so that we don't miss anything. Because it's the challenge is it's a big garbage pail of patients, right? Like, I don't mean that negatively. Sure. Like, it's a bucket of patients that we don't really know what went on. We know that it's reassuring right now. The exam's reassuring, the vital signs are reassuring, but is there something else going on? And I think there's about 6% of kids that will have some serious diagnosis from a BRUE. And so we just don't want to miss those diagnoses.
And Jamie, you alluded to guidelines that help to define the risk stratification. Where would our listeners find those? Yeah,
if you just go onto the AAP website, you can definitely find those. In fact, a few years back, they did a great publication of that, defining the low risk stratification criteria. And if it doesn't meet the low risk, then it automatically puts you into high risk.
Good. Well, I appreciate you guys both sharing both your experience and your knowledge on this topic. It's been really wonderful talking to you. One thing I've learned from you, Mike, and you, Jamie, is that you guys are not only experts in this, but master communicators too with families. So I think we've all picked up some tips. So how about a round of applause for these two experts? Yeah.